you've got to okay that, right? Okay, ladies and gentlemen, you're listening to the Louis B. Free radio show, Brain Food from the Heartland. Again, I'm in the midst of some dental stuff, so please forgive my obvious lisp. Today, I'm delighted and honored to have returning to the show, Dr. Jeffrey Singer. Doc, welcome back.
Happy to be here.
Always love talking with you. I always ask you this, but for new listeners, a little bit about yourself and your background, if you would.
I'm a general surgeon in private practice in Phoenix, Arizona. I've been in practice for 40 years now, which makes me seem old. And I'm a senior fellow at the Cato Institute in Washington, D.C., in the Department of Health Policy Studies, where I focus on health policy. And I grew up, went to undergrad and med school in New York, so you could probably tell by my accent that I don't sound like an Arizonan, but I've been living in Arizona long enough that I qualify as a native Arizonan at this point.
The advocacy that you do, your involvement with Cato, et cetera, what drives you to do that?
Ever since I reached adulthood, I always considered it's very important to speak out and get involved in public policy issues that impact everyone, not just to be a kind of a silent observer. That's just in my nature. So as long as I can remember.
Yeah. I mean, the way you were raised, I'm always interested in where that, because you don't have to put your head up. You could keep your head down, successful, have a wonderful life in Arizona. And
yeah, my father was a New York taxi driver. I came up in a blue collar household, but very opinionated, as taxi drivers were back in those days. Always heard lots of heated arguments about different topics of the day between my father and members of the family or friends. And most of the time I was too young to even know what they were talking about, but I did pick up that, these kind of things matter. You don't just shrug it off. So maybe I'm sure that influenced me.
And those were days that you could really strongly disagree with somebody and remain friendly with them. That's the part that I don't get today.
It was great. You can have like an argument where you think you're going to come to blows.
Yeah. Right.
And then as soon as you're done discussing,
you're hugging.
You're hugging and talking about you can't wait for the next Mets game or something. And
I don't understand that today. I mean, you could have a really, really lively, you could be swearing at each other. I'm not saying this is a good idea, screaming at each other and then hug it out afterwards. I think they call it. And
you're not taking it personal.
Or have a
you're
beer
not taking it personal.
Yeah.
Because you're looking at each other as a whole person.
Yeah.
And you're just saying on this particular thing, he and I just we don't see eye to eye.
Yeah. And the way it is with social media, again, I mentioned this a lot on the show. It bothered me in 2016. If you voted for Hillary, unfriend me. If you voted for Trump, unfriend you? Where are you going to get different ideas if you won't want to hear an echo of yourself? I'm sorry, I'm going on and on about that. Let's talk about, sorry. Doc, let's talk about the recent Soho Forum and what you did. And
last week was a pretty big week for me because two things happened. Interestingly, both on the same day. So I'd like to get a chance to talk about both of them. On June 7th, a policy analysis that I'd done with a colleague at the Cato Institute on state drug paraphernalia laws and how they don't allow harm reduction programs to flourish came out. And then later that same day, I appeared in a debate at the Sheen Center for the Soho Forum in New York City, in the Soho section of New York City. The Soho Forum has been around for many years, I think at least 10, and it's affiliated with Reason magazine. But it's organized by Gene Epstein, who was for many years the economics editor for Barron's. And it's just it's a monthly Oxford style debate. So it's not like a politician's debate, it's a real debate. And it's scholarly, it's kept above board, very, you maintain decorum. And the way it works is that there's a resolution that one of the two debaters is supposed to defend. And the audience gets to vote online before the debate takes place, either agreeing, disagreeing, or undecided with the resolution. And then the debate takes place, and there's this typical format where the defender of the resolution goes first, then the opponent of it, then there's a rebuttal for 5 minutes for each of them. Then they get to ask each other questions, and people in the audience get to go up and fire questions at one or both of the debaters. And then they have a summation, and then there's another vote. And whoever, the way Oxford rules work is whoever moves the most votes is the winner of the debate. So you could actually, if you have a majority of people agreeing with you before you start, that could put you at a disadvantage. Let's say, you take a very popular position, and before the vote even starts, you got 65 agree with you, 25 disagree, and 10% are undecided. And then after the debate, let's say 3% move to you, so now you're up to 68, and the other 7 move to your opponent. So that person is, 32, still in terrible shape, but that person technically won the debate because that person moved more minds.
Yeah,
So that's the way the Oxford rules work.
I'm not sure how I feel about that.
I'm not sure either.
I get the idea that how many people do you, I'm not sure that that's a fair.
Yeah, and also there's a lot of opportunity to game it, because on both sides you can get your friends to vote against you beforehand,
Initially,
so that they could, with the intention of voting for you afterwards, so that way you move the vote.
Stack the
So to me, the most important thing is it's a chance to communicate your views to the audience, and it's also to me, the final vote is the one that counts, because that's the one that there's no gaming, that the people are telling you what they really think. It's held live, and then in fact, I'm told that sometime today, if your listeners want to see it because they missed it, because you could buy tickets to be there, or you could buy tickets to watch it live stream, but that was last week already. It's going to be uploaded to the reason.com website. It's reason.com. And you'll probably see it on the homepage sometime later today. And you can click on it, you can watch its entirety. It's a YouTube video, so you could pause it whenever you want, rewatch it. So you could draw your own conclusions. I thought for me it was very good. A lot of these they intentionally choose topics that are interesting and divisive. Even though the Soul Forum and Reason are libertarian organizations, the audience there's a lot more libertarians in the audience than in a general audience, but still the audience is very mixed, and they often pick topics that even libertarians get into disagreements over intentionally to make it interesting. So, and then when it's uploaded to Reason, lots of views. A couple of these events had 5 million views afterwards. So it's widely distributed by people. So I encourage anyone listening who regrets having missed it, don't despair. Sometime probably later today, you'll be able to go watch it, and you could share it with your friends.
And the audio is up now. I mean, if you want to listen,
the audio is up now. It's a little scratchy.
A little bit. Yeah. You get it. I mean,
and
I listened to. Go ahead.
The other thing you miss out with the audio is you miss the body language, because that, I think, to me at least, you see gestures and expressions made by the speakers that, at least I thought, makes a difference. So the resolution that was that my opponent was Dr. Adrienne Fu Berman. She's a professor of physiology and pharmacology at Georgetown Medical School. She's not a practicing, she's not a clinician, she's a researcher. And she opened by admitting that she also does expert testimony in all of these cases brought by attorneys general, et cetera, against the pharmaceutical companies for supposedly causing the overdose crisis. And the resolution that she actually proposed that she wanted to defend was the overdose crisis is the result of doctors over treating patients with opioids. And I was opposing that resolution. And at the end, my position carried 45-39. The rest were undecided. I maintain.
Forgive me, because you're correct.
Well, that's what I'd like to think. She gave the standard arguments that probably by now everybody's familiar with, that everything was fine until these greedy pharmaceutical companies tricked doctors into using opioids for treating chronic pain.
Forgive me, Doc, because doctors are so easily fooled.
Oh, yeah, she actually said that doctors are very easily manipulated. They have no understanding of marketing or sales. Because, of course, I'm a doctor. I never buy anything. I don't buy a car. I don't buy a computer. I don't buy a house. So I'm very easily manipulated. it's amazing that I'm not out on the street, homeless, because think of all these people who've manipulated me over the years. So yeah, and I've been manipulated by the drug companies into over prescribing, and that opioids are really highly dangerous and highly addictive. And but for that, everything would be fine. And I countered with actually, and people hear it. I mean, this is my opening comment that during the 70s and 80s and 90s, when people were dying of drug overdoses. Oh, by the way, there's incontrovertible evidence based on research performed by members of the CDC and the University of Pittsburgh School of Public Health, showing the overdose rate has been an exponential increase since at least the late 70s, and is showing no signs of letting up. The only thing that's changed at any point in time is which drugs seem to be the more predominant among the overdose deaths. And recently, the Joint Economic Committee of Congress had a report showing actually overdoses started going up around 1959. So I argue that, during the 70s, 80s, and 90s, when overdose deaths were predominantly reported among, minorities, inner city people, we blamed them. We said, well, you're immoral, you shouldn't be doing drugs, you made bad choices. Then when all of a sudden, middle-class white people started appearing in the statistics around, late 90s, early 2000s, we blamed the pharmaceutical, they were victims of the pharmaceutical companies and of doctors, many of whom were fooled into prescribing opioids. Nobody wants to place the blame where it's always belonged, which is with drug prohibition. There's a growing population, obviously, of people willing to use drugs non-medically, either for recreational use or maybe they're self-medicating. There's lots of different reasons, but there's a growing population. Why it's growing, it's beyond my area of expertise. That's for social psychologists and sociologists and anthropologists to maybe, delve into, but it's growing. And they're also willing to take risks these days that, our generation wasn't. I cite a study by Ted Cicero at Washington University in St. Louis. He's a very respected researcher, where he shows that 33% of heroin addicts who were entering rehab in the year 2015, when surveyed, said they initiated their non-medical drug use with heroin. In other words, heroin was their gateway drug. That's what they started with, okay? They didn't need doctors to prescribe anything to them to start heroin. And only 9% gave that answer 10 years earlier. So there are people who are willing to take risks that, in our generation, that sounded too risky. We thought we were living on the edge by smoking marijuana in our generation. Anyway, there's a growing population, and in the early 2000s, since doctors were prescribing opioids more liberally than before, and I would argue that was a good thing because they were under-treating pain up until then, the more drugs are prescribed, the more are available for what the people in the policy world call diversion into the black market. And the non-medical drug users, that was their drug of choice. And I even mentioned in my debate points that, as a doctor, actually, if you're going to use non-medically, that's a good choice, because if it says oxycodone 5 milligrams, it's oxycodone 5 milligrams. It's not something else. It's not 100 milligrams. Yeah. It's not laced with fentanyl. It's pure. So if you're going to do something, if you're telling me, hey, doc, I'm going to do something, whether you like it or not. Should I use this bag that I bought from this guy on the street, or should I use these oxycodone pills I stole out of grandma's medicine cabinet?
Except now they're pressing pills with fentanyl. Now,
right. Yeah. But that's what I say. If you stole them out of grandma's medicine, actually, we get into that too. That what's happening is even today, a lot of the non-medical users, there was Dr. Dan Ciccarone at UC San Francisco Medical School. He was doing this National Institute on Health study, National Institutes of Health study called Heroin in Transition. He spoke at the Cato Institute, and his research, because they go out on the street and they talk to heroin users and other IV drug users on the streets there, and just to try to understand, what's going on in their lives. And he ascertained that most of them, they're not wanting to use fentanyl. Actually, it gives them a totally different experience. They view it as a contaminant. There's some who like it, but most of them like either heroin, the feeling they get from heroin, which is a totally different experience, or, stolen prescription pain pills. But, the black market, as I said in my presentation, you don't get those kind of choices. It's not like you're shopping on Amazon.
Right.
You get what you could get. And that's, of course, why prohibition is the killer.
Yeah.
And
if you don't,
so that was my argument.
and Dr. Singer, I probably brought this up to you before. A former younger coworker of mine I've stayed in touch with, and friends, and he was telling me about he said, Louis, and I'm going to say, obviously, you know a lot more about drugs than I do, having talked about a lot on the show, my drug use, etc. He said, I was shocked because my cousin died on his 30th birthday. They had gone to a concert and they feel that it was a heroin overdose. And I talked to him a little bit about fentanyl. I said, look, I don't know, but I don't know that he was a heroin user, et cetera. He calls me a couple of weeks later and said that they had bought some cocaine to celebrate the birthday. I'm not judging, I'm not saying good, bad, but it had fentanyl in it. And he died on his 30th birthday. Again, whether people think you should be able to buy cocaine legally over the counter or whatever, at least they would know what it is. They went out and found it, and he's dead. A 30-year-old is dead.
What's happening is, in fact, I point this out. This again goes against the I'm giving my argument here. So first of all, I cite data from the government showing that the addiction rate of adults age 12 and up, the percentage of the population addicted to prescription pain pills, has been unchanged in roughly around 1.2% since they started taking the survey in 2002. So how are we creating this overdose crisis? Don't you have to increase the number of addicts? That's number one. Number two, now about over 90% of all overdose deaths are what they call poly drugs. So when they, when they sample, when they do toxicology studies on the corpse, they'll find multiple drugs. They'll find opioids, which is a whole category of drugs. They'll find cocaine, methamphetamine. In fact, they're finding now cocaine or methamphetamine in at least half, more than half actually, of the overdose victims. So, and Xanax and other benzodiazepines and alcohol. And I pointed out that, number one, we never prescribe cocktails to our patients in pain of cocaine mixed with fentanyl, mixed with prescription pain pill. Number two, if you are addicted to an opioid, what about being addicted to opioid compels you to want to use cocaine? There's no reason why you should want to use cocaine if you got addicted to a prescription pain pill. So the whole thing is, to me, in my mind, is illogical. And all you have to do is look at the data. I can understand there's a temptation we all have, and I'm guilty at times too. You want to blame somebody, and you want an easy target to blame.
Sure.
So the pharmaceutical companies are an easy target. I mean, they're the people you love to hate. At the other time, it's a love-hate relationship. When they come up with a miracle drug that cures, diseases, we love them, but we also hate them because they gain the patents and they make us pay a lot more for pharmaceuticals, et cetera, et cetera. So it's a love-hate relationship. So right now, they're an easy target to be the bad guy. And then you kind of like doctors. You don't want to say bad things about us. So instead of saying they're evil, trying to hook our kids on drugs, you say they were fooled because they're innocent. They're innocent little naifs who were fooled by the evil pharmaceutical companies. It's an easy one to want to grab onto, but the data doesn't go. It doesn't make sense. You just sit back and think and look at the data. It doesn't make sense. And so again, anyway, about the cocaine thing. We're seeing a lot of that, and in fact, reports out of Massachusetts Department of Health show that something like, I think it was like over 90% of the overdose deaths now are fentanyl, and most of them have cocaine. Now, I know there's a popular mixture that cocaine users like. It's called speedballing, where you kind of mix cocaine with heroin, and it's supposed. I don't have personal experience with this, but from reading about it, it's supposed to make it. The combination is supposed to, when you're speeding from the cocaine starts to come down, the heroin gives it a nice landing, so to speak, and that's very popular. In fact, I think John Belushi was speedballing with heroin when he overdosed back, from the Saturday Night Live show. So fentanyl is replacing heroin, And a lot of that, by the way, is COVID related. That may sound weird, but there are supply chain issues. First of all, listeners should know there's a phenomenon that economists refer to called the iron law of prohibition. That's what it's called, which is as law enforcement gets more intense, the drugs prohibited get more potent. Or in shorthand, the harder the law, the harder the drug. And that economists will tell you it makes sense because if you're going to take risks, then you got an incentive to come up with more potent forms of the drug that you can get more bang for the buck. If you're going to take a chance smuggling it, you could subdivide it into smaller parts and sell it to more people. When you think about during alcohol prohibition, they weren't smuggling in beer and wine, they were smuggling in whiskey. And there's a real world demonstration of the iron law today in the legal world. Anybody who goes to a football game, you'll notice outside the tailgaters are drinking beer and wine, but you're not allowed to bring any alcohol into the stadium. So when they smuggle in alcohol, they usually smuggle in the hard stuff, not the beer and wine. So there's the iron law of prohibition, in action. So that was what was already, if you looked at the data around 2014, 15, and 16, you start seeing fentanyl, which could be made in the lab. I mean, it's a regular drug, and so is methamphetamine, by the way. It's called disoxin. It's a drug that's legally prescribed to treat ADHD. It's not as popular anymore as Adderall, but it's around. But you can make it in a powdered form in the lab. So the cartels are doing this, and first they were adding it to their mixtures of heroin because they could then smuggle in smaller packages of heroin because you just increase its potency. Fentanyl is about 50 times the potency of heroin. But then during, particularly in recent years with the COVID pandemic, supply chain issues also affected heroin because heroin, has to be derived from the opium poppy. You got to process it. Then once you process it, you got to then smuggle it. And the supply chain was disrupted because of borders being closed and all sorts of things. So fentanyl became an easy go-to substitute. So now you're seeing, if you look at the latest data, heroin overdose deaths are actually down, as are overdose deaths that contain prescription opioids. Oh, and incidentally, by 2017, according to the CDC's numbers, only less than 10% of overdose deaths involved prescription pain pills with nothing else that weren't with other drugs on board. So anyway, getting back to my point, I think what's happening is when they're smuggling in cocaine, and they used to smuggle it in mixed with heroin, now they're smuggling in mixed with fentanyl because it's easier to get fentanyl. Yeah. And so users aren't aware that what they're using is 50 times more potent than the heroin they're used to using, or they may not even be aware that there's any opioid in it. They may think they're buying just pure cocaine, but what they got had fentanyl in it. And so we're seeing a lot. You probably remember there were these military guys in Florida about 6 weeks ago.
Yeah.
They were doing cocaine and they overdosed with fentanyl.
Yeah.
This is what happens, by the way, with prohibition. Because when I go to the liquor store, I do a drug called alcohol. And I'm a regular user. I would say about 5 out of 7 evenings a week, I do that drug. And usually not a lot before dinner. So my dealer, my preferred dealer is Total Wine. This is not an advertisement, by the way. And when I go to my dealer and I'm looking at I like bourbon. So I'm looking at the bourbon section and I'll ask him all sorts of questions and he'll tell me the differences between one and the other and what kind of, depends on what I'm looking for. And then I'll notice on the label, it may say something like 45% alcohol, which bourbon is pretty strong stuff. And, it never even enters my mind that maybe they're lying. Maybe it's 60% alcohol and I'll overdose on alcohol, or maybe there's fentanyl in it, or maybe it's laced with
you don't have
arsenic. You know why? Because it's legal. And when it's legal, it's regulated both by the market, by tort law, and by law. And so, and plus, if the makers of a particular brand of bourbon get associated with some, terrible outcomes, overdose deaths or something like that, it's not good for business, So, So in fact, during the debate, I was asked both by my opponent and by someone else who went up to the mic. So you're saying that these drugs should be available legally over the counter? And maybe it was shocking to some. I guess it would be, but I said, yeah, that's what I've been saying all along, that it's prohibition that's killing people. And, you know, I don't have to get a prescription to buy bourbon, you know? So now if
And
I'm
look at
buying,
how many people get killed by drunk drive, you know, and how many people die from liver, you know, I mean.
yeah, actually, alcohol is more dangerous than opioids because continued use of alcohol can kill your liver, cause brain damage, encephalopathy, heart damage, all sorts of problems. Continued use of opioids doesn't do those kind of things. You know, causes constipation.
I don't want to digress too much, Dr. Singer, but again, I always bring up the diabetes. Don't we have an epidemic of diabetes in America? How many people die from complications of diabetes? I think my thought is, I think there's so much money in that market. I've used this example. I'm not diabetic. No one close to me is diabetic. I know about A1C. How? From commercials on TV. I know about an A1C, and there's so much money for the drug companies and treating, et cetera. I instead of, you know, the government, if they want to wake up about something, about a crisis in America, I think that's one of them. Any thoughts on that?
Well, yeah, and a lot of that
by the
has
way,
to
I'm not
do.
criticizing people. I'm not out to criticize people who are diabetic, but there are lifestyle changes that can be made.
Yeah, I think what you're saying is we need to put things in perspective.
Yes.
So everybody is talking about the overdose crisis, and it is. I mean, I don't want to belittle it, but most people are probably not aware that 88,000 people die a year from alcohol, and nobody's proposing to shut down the alcohol dealers and go back to alcohol prohibition. So when and with most drugs, if you don't require a prescription, which, you know, I look at as basically you're an adult and you got to get a permission slip from another adult in order to put something into your body, that even if you're making a mistake, it's your body and you can decide what you want to do. I mean, you don't have to get permission from another adult to eat a real fatty steak. You know, you don't have to get a prescription for that because, you know, it could be bad for you.
Yeah.
But you do have to get a prescription to take a drug. Now, most people are not going to take some drug that they just heard about without going to an expert. They have a right to, in my opinion, but the average rational person, before they start treating themselves, they're going to do due diligence. They're going to read up on it, see what the side effects are of this thing they're putting in their body, whether it reacts with anything else they're taking. And it'd be very wise, unless you already know a lot about it and had experience with it, to go see somebody like a doctor,
professional, yeah,
and say, what do you think? And that's what people were doing, by the way, prior to 1951. Prior to 1951, there were plenty of prescriptions written. In fact, most people, 75% of people who went to the pharmacy to get their prescriptions, to get their drugs, went with a prescription from a doctor, but it was not required. And lots of times they'd have a discussion with a pharmacist, and the pharmacist might suggest something else. And, you know, they were autonomous adults, and they would end up deciding whose opinion they wanted to listen to, because you're adults. Now, we're not talking about children, we're talking about adults.
Yeah.
Anyway, so I would encourage your viewers to, your listeners, I'm sorry, to take a look at the Soho Forum debate, and they could decide for themselves who carried the day. We kept it very respectful. We shook hands before and after.
I know. But people
every time my opponent got up to speak, when she was done, I politely applauded. I assume she did the same for me, because that's the way these debates are conducted. Yeah. It's like, you know,
decorum, as you said, old school. Decorum. Yeah. And the other aspect of punishing legitimate pain patients, when she said some of the things she said, well, yes, for end of life or cancer. Well, there's other issues. There's chronic issues that people have, and other pain issues. And the way, and I don't certainly don't wish this on her, but I wonder what would happen. She would probably have access to some doctor that would prescribe opioids for her if she needed it. I don't think she would ever go public and say so. But until it happens to you, you and I've talked about this, about that Pastor Niemöller quote, until they came for me, and I'm not going to read it again, but I didn't stand up because I wasn't wanted. But you're not in pain, so you can say, yes, they shouldn't prescribe them. Until you or somebody you care about, someone you love, needs pain medication, that's when everything changes.
Yeah. In fact,
and it shouldn't have to get to that point. I'm sorry.
So many patients are getting desperate. I wrote an article. Another thing I might want to direct your listeners to. that same day, that was a big day, June 7th, an article came out in Reason that I co-authored with Dr. Richard Menger, who's a neurosurgeon and a spine specialist, and he heads the complex spinal surgery program at the University of South Alabama Medical School. He's a professor. And he was really taken by that shooter in Tulsa, Oklahoma, who shot his spine surgeon, clearly made because he was unhappy because he was not getting his pain treated.
Yeah.
And so we wrote about that.
Right.
And now, of course, there's no excuse. We're not trying to excuse that
not.
person's behavior, but that's how bad it's. He said he's under pressure from his employers at the medical school, plus the licensing board, plus regulators in his state to under medicate, and he feels terrible about it. And he says it's pushing him into an adversarial relationship with his patients, and that's not why he got into this business. He went into this business to be their friend, to help them, and he feels terrible. And he's looking at what happened to Dr. Phillips, who was assassinated, and thinking, I'm there, but for the grace of God, go I. So we wrote about that. It's another thing they can look at.
And there's people that have committed suicide because of,
suicide,
yeah. And we don't.
Or they go to the black market and they think they're buying oxycodone, and it's fentanyl that was made to look like oxycodone. Yeah.
And they die. And that, I feel this is one of those things that future generations will look back on us and say, I'm not going to use an expletive. What was wrong with it? Why were they not thinking? Why were they?
It's all based upon this irrational bias against a particular drug,
To me, it's a distraction. It's also a distraction.
And many people don't know, prior to 1914, this stuff was legal. I mean, they put cocaine in Coca-Cola, Moxie. You bought opium through, the Sears catalog over the counter. The heroin was a cough syrup for children.
Wow.
Heroin is from the German word heroish, which means stronger. It's just diacetylmorphine. It's one molecule added onto the morphine to make it about twice as powerful. It's about the same potency as oxycodone, by the way. And it was taken off the market in the United States because the drug czar at the time, he thought it corrupted your morals, which was totally irrational and not scientific. Morals. It's on the drug formulary in much of in Canada, the UK, Europe. It's on the drug formulary. They just don't call it by the brand name heroin anymore because that's got a lot of baggage. They call it diamorphine. And listeners could look it up. Doctors will prescribe diamorphine. It wears off rather quickly, but it takes effect quickly, and it's about half the strength of Dilaudid, which is prescribed all the time. You got morphine, and then about 2.5 times the strength of morphine is heroin, and then 2.5 times the strength, 5 times the strength of morphine is Dilaudid or hydromorphone.
It's outrageous what's going on. And you say it again, I'm going to say it again about the pain patients, legitimate pain patients being punished and pushed in, and some having to go to clinics, drug clinics.
I don't even like the word legitimate, by the way, because I think everybody's legitimate.
Yeah. Okay. Yeah, that's a good point. I appreciate that. I guess people that, not people.
I know what you mean.
Seeking behavior, people that are using it for the right reasons, not recreational. Not that I'm saying there's anything wrong with people using it recreational.
Yeah.
No, people, like you say, with alcohol, there are people that abuse it, and there are people like myself. I refer to the way my alcohol is medicinal. I use it medicinally. That's how I.
If we have time, I'd like to get in the other thing that happened on June 7th.
I want to get into that. I want to talk about what's going on the 17th, provided that you have time.
Yeah.
Dr. Singer, go ahead.
Well, at the same day, the Cato Institute published a policy analysis that I've been working on for months with my colleague, Sophia Heimowitz, and it's called Drug Paraphernalia Laws Undermine Harm Reduction. And I'll be real brief, but you could go to the Cato website, cato.org. It's right now on the homepage. It'll be there for a little while, and then you'll have to go under my name to get it.
I also have a link up at Louis Befree, I think it's .com, the news, louisfreeshow.com and wfmj.com. I don't even know where things are posted anymore. Sorry, go ahead.
Okay, well, policymakers, including federal and state, they're all starting to realize that harm reduction, we got to start embracing harm reduction to stop these overdose deaths. And one thing that from the Surgeon General in the Trump administration to the current drug czar and the Biden administration are all advocating is that states allow syringe services programs to develop. That's what they call them now. They used to be called needle exchange programs, but they're more actually do more than that. They hand out fentanyl test strips to test the drug to make sure it's not containing fentanyl. They hand out naloxone, so in case there's an overdose. They make available rehab services if you're interested. They offer testing for HIV and hepatitis. So that's why they call them syringe services programs. The problem is that states have these laws called drug paraphernalia laws. This is a state level thing where it says it is illegal to possess or sell or distribute drug paraphernalia. And then it defines by drug paraphernalia we mean, and basically it's anything used to consume, make, or test illicit drugs, controlled substances, okay? And so that makes it tough because if you want to set up a needle exchange program, you're handing out syringes, which are considered drug paraphernalia, for example, or fentanyl test strips. You can get arrested for giving a fentanyl test strip to somebody and make sure there's no fentanyl in the drug. So that's what stands in the way. So we did a study of all 50 states in the District of Columbia, and to our surprise, we found there's one state that doesn't have drug paraphernalia laws. That's Alaska. Alaska, if you wanted to set up a harm reduction program, you're not going to be violating any state laws.
Wow.
And
Interesting.
but all the other states do. Now, some states have, because they want to allow syringe services programs to exist, they passed explicit laws saying we will allow syringe services programs to exist as an exception to our drug paraphernalia law, but they must meet these criteria. And sometimes those criteria are so rigid that it's unworkable. Or they put a limit on how many can exist. In Ohio, I think there's a limit on how many can exist, and they have to be certified each year by the County Department of Health. Some states say you got to collect the same amount of needles that you give out. Well, that could be tough because a lot of these people don't have their needles with them. So that makes it hard for you. Some of these programs come up with workarounds, like they have volunteers go out and on the street to try to collect some needles and syringes, or ask if you have any friends or relatives who have diabetes when they're done with their syringes, can we have them? Because we have to have the same number as we gave out when the inspectors come. But still, a lot of stupid rules like that. A lot of states have it explicitly on the book saying syringe service programs are prohibited. Okay. And then there are a lot of states where it's just not clearly addressed in the law. So if you want to set up one of these harm reduction programs, you don't know, is this against the law or not? I don't know where I stand. So we get into all of that. We're going to have this Friday, June 17th, from noon to 1 Eastern. I'm going to have an online policy forum. It's free. Anybody who wants to view it, just go on the Cato website and register for it. You see at the bottom of the page, it has upcoming events. Just register, and then you will get a reminder, a few hours beforehand to click on the link and it takes you to it. And you'll be able to ask questions on the event page, or it's also going to be on Facebook, Twitter, and YouTube. And you can ask questions there as well. And what we're going to do is we're going to have Corey Davis, who's a JD, and he's also got a master's in public health, and he's with the the Harm Reduction Project for Network for Public Health Law. He also is an adjunct teacher at the Eastern Carolina Medical School. He's really an expert on this issue, and he's published a lot on it. In fact, a lot of his work is what influenced me. He's going to be on. He's going to talk about the policy analysis that we did, give his opinion, and in light of what he knows, and share his own information. Then we're going to have on Robin Lutz, who's the executive director of the Alaskan AIDS Assistance Association, which is the oldest continuing harm reduction organization in Alaska. So we're going to ask her. So, Robin, tell us what it's like when doing what you want to do in a state that doesn't have any state laws that block you. And then we're going to have on Haley Coles, who's the executive director of the Sonoran Prevention Works, which is the oldest continuous harm reduction organization in Arizona, where I am. And full disclosure, I was recently elected to their board of directors. And up until May of 2021, it was illegal to hand out fentanyl test strips. It was drug paraphernalia. You can get arrested for that. And also, it was illegal to have
for that. That's outrageous. Yeah. Go ahead. I'm sorry.
Well, that's like most states. That's the way it is in most states. It was also illegal to have syringe services programs. Both two laws were passed in May of 2021. One took fentanyl test strips off of this list of drug paraphernalia was said, this is not drug paraphernalia. So that way you won't get arrested. And the other allowed syringe services programs in the state of Arizona, but it had, again, some attachments. You have to collect the same amount of needles total. It's not one for one. It's not like I have to collect one from you. Like in Florida, I have to get one from you before I can give you one. In Arizona, I just have to have at the end of a certain period of time, I have to be able to show an inspector that I've collected the same amount of syringes that I handed out. So that one's a little easier to work around because you can have friends bring in, diabetes needles and stuff. But so she's going to talk about how it is now and also how it was before that law was passed. So it should be an interesting discussion. It's an hour long. We'll take questions. And I encourage any viewers who are, again, I keep saying viewers.
I have
Encourage any
listeners and viewers.
listeners.
It's cool. It's
Right.
cool.
Okay. I encourage people who are interested in this subject because, and this doesn't even necessarily have to involve taxpayer money. There are people who say, I don't want my tax dollars going to give out needles to drug users. And you could argue, well, would you
might be
rather have your
saving-
tax
yeah.
dollars go to paying for their HIV treatment?
Right.
But besides that, the fact is there are a lot of private organizations that are privately funded that then they're not asking for government money. They have donors, sometimes wealthy donors who maybe lost a loved one to a drug overdose, and this became an important issue to them. But they're not being able. So there are people out there who are being non-judgmental. They're saying, I don't want you to die. I'm not necessarily approving of what you're doing, but I don't want you to die. You deserve to live. Let me help you reduce your chances of dying, make what you're doing less dangerous. And they're being blocked.
Yeah,
And
which is
and
outrageous.
by these laws. We need to get rid of the drug paraphernalia laws and emulate Alaska. That's actually the subtitle of our policy analysis is states should emulate Alaska.
And I've got links up to the article also at Cato, the policy analysis. And Dr. Singer, you just reminded me, and I think this was very early in my radio days when I had someone about harm reduction, and I think they were from Amsterdam, when they were just, it was new to me, at least the idea, the concept of harm reduction. And I think they were starting to do some things in New York, but it's so important. And again, even out of the tax idea that saving tax dollars, you're saving people that might go in the hospital that don't have money, don't have insurance, whatever. It's beneficial for all of us. It's not encouraging people. It's not encouraging people. You're not pushing drugs on them. You're making it safe. Go ahead.
Right. Well, when you think about it, this is what doctors do all the time. In an affluent society, how many people are dying each year from basically lifestyle choices, whether you're overweight, you're eating the wrong foods,
don't exercise.
So when a doctor has a patient who's developed diabetes and high blood pressure and is overweight, and they know they can get them, they don't need to use medication. If they could just get them to go on this diet and exercise regimen and get them down to and be in good shape, but the patient, for whatever reason, either can't or doesn't want to. So when the doctor prescribes a blood pressure pill and a statin drug to lower the cholesterol and that kind of thing, they're practicing harm reduction. They're basically saying, all right, let me give you some medicine that's going to make your decision less dangerous. It's going to reduce the chances that what you're doing is going to kill you. Or now alcohol is legal, right? So when a person says, I'm going to go out, I'm going to drink a lot at this party tonight, so I'm not going to drive. I'm going to get a designated driver. That's a form of harm reduction. Or your friends say, let's call Uber. Let's not drive to this place because we're going to drink too much. That's harm reduction. So it's really not an alien concept. It's just that people don't want to consider it when it comes to certain particular lifestyle choices because they're moralizing.
Yeah, because it's not their lifestyle choice.
Yeah, and that's no reason to stop people who want to prevent people from dying.
You're incredible. And I know you got a split, but hopefully we'll be able to talk sometime in the near future about how things go on the 17th. I'm always honored to have you on, Dr. Jeffrey Singer. Your courage, I love when courage and intelligence and experience come together. You can be courageous and not really know you can speak up and not really know what you're talking about, or you can know a lot, not speak up. You're the blend of all those. And I'm grateful to know you. Thank you so much.
Thank you.
We've got those links up at louisfreeshow.com. It'll be available also in podcasts, and it'll just a little bit as soon as I get it together. Within the hour, and